So let's jump into our next rewarding career opportunity in healthcare, which provides compassion support during someone's most challenging moments of their life, helping patients and families navigate emotional, financial, and care related concerns. The team from AdventHealth shares the care options available in social services.
You are brilliant. A candle of caregiving reflected in others' eyes. A spirit of service that looks like someone's sunrise. So let the porch light of your good work shine. So bright, let it shine like your community's lifeline. And let darkness know you are coming for it. With all your purpose and all your might. With all your people and all your light. And you gon' let it shine. AdventHealth. Feel whole.
Hear from our panel about the career opportunities working in social services. Joining us this morning from AdventHealth are two social workers, Annie Bartolak and Pam Toohill, who is also a doctoral student at KU School of Welfare. Good morning.
Good morning.
Good to see you guys.
Great to see you too. Thanks for having us.
Thank you so much for being on. So we want to kickstart this session with a little bit about each of you. So can you each tell us about specifically what you do in your career as a social worker? Because I know it's a little different for each of you. So Annie, let's start with you.
Yeah, so I am the ICU social worker at AdventHealth on the adult side. So I work with the most critical care patients, kind of navigating care coordination and setting up discharge planning as we go forward. And I've been in this role for almost 3 years.
Okay, so Pam, what about you? What do you actually do in your specifically for your career in social work?
Yeah, good morning. So I'm the mother baby social worker. I'm actually one of 3 on our team. And our role is that we support mothers and partners and families. So that includes children and other members of the family and feeling successful and prepared to navigate that transition of taking home a baby. Sometimes it's not their first baby, and that can look like so many different situations. So we help with adoption, surrogacy, foster care, sort of runs the gamut. And I have been with AdventHealth for about 6.5, maybe 7 years, starting in the home health side. And then I transitioned into the hospital setting probably about 4-ish years ago.
That's great. There are so many positions in social work. I hear there are so many places you can take this degree, but I'm really curious from each of you, like what education did you have? And then also what experience did you have in addition to your education to get you into the position you are in a hospital today? So I don't know, Pam, do you want to start first this time?
Yeah, sure, certainly. My education background is that I actually have my undergraduate degree in secondary education. So I thought I wanted to be a high school teacher. And I learned pretty quickly that I loved working with people, but being in a classroom for that age group was not my exact calling. And so shortly after I finished that degree, I worked for several years. And then I spent some time thinking, like, what are my strengths? What am I meant to do? Where am I going to best be fit? And so it really became clear that social work was the path for me. I went on to get my master's. And at that point, once you have your master's, you can start to have different on the job, and really with your bachelor's too, you can have on the job experience. And then in social work, there's like a licensing process, and that's a little bit tiered, but that's my education history in a very small nutshell.
Well, I mean, that's great. Before I jump to Annie, how long was that process? Like, how long did that take for you to get from A to B?
Sure. So, of course, my bachelor's was a 4-year program out of high school. And then several years passed before I went back for my master's. And that master's program, mine was 2 years, but people can do it in a shortened version, which I believe is 1 year. That track is out there. I don't know what options there are in Kansas, but I have heard of that. And then you, with the licensing, that process can take a bit longer, but people kind of are able to do that licensing process at their own pace. And again, there's different sort of levels of licensing that people can obtain, but you certainly do not have to have that to initiate your career in social work. You certainly do not.
Okay. Well, Annie, you probably have a different path and different education background a little bit. So why don't you tell us about your education and experiences to get you where you are today?
Yeah, so I always knew I wanted to work in healthcare, but I realized I wasn't great at math and chemistry and all that stuff. I thought I was going to be a nurse, realized that was not my calling either. So when I went into my freshman year of undergrad, just kind of took a wide variety of classes. I went to Kansas State University and learned I was really good at talking to people and listening and collaborating. And so I kind of honed in on the social work fields there. So I learned, this is it. Social work's what I want to do. And I knew I wanted to do healthcare. And so a big thing in healthcare is they usually require a master's degree. So after 4 years of my undergraduate, I went on the accelerated program straight into my master's. So I graduated in May and I started in June. And it's a 12-month straight accelerated program through the University of Kansas. So kind of what Pam was saying, I did do that accelerated program. And typically with those programs, usually they require you to qualify if you have an undergraduate of social work degree within 5 years. And so typically if you have a different degree, they require the 2 year. So I had the undergraduate, it was right after I graduated. So I got accelerated and then started in hospice. I did my both undergrad and graduate, you are required to do a practicum, so you are in the field working. And I worked in a nursing home and then in hospice. So I started out my career in hospice during COVID, which was, a different time for everybody. So after that, I learned, I wanted to be kind of have a home base and have a team, whereas hospice, you do travel a lot. I loved my time. But I wanted to kind of stay settled in a home base. So that's when I transitioned. And I still use a lot of my experience from hospice in the ICU setting, having those goals of care conversations, palliative conversations. It gave me a lot of experience in that realm.
That is great. That's so good to hear about the different options on the path. And Annie, for you, that you made most people on the call happy because you had K-State and KU in there. So good job on both schools.
Both schools.
Both schools. So what does it mean to care for the whole patient? Like not just their medical condition. I know that's a really important part of what you guys do.
Yeah, sure. I can start. So a big part of that I learned on the ICU specifically is a lot of patients are given a lot of medical jargon that they may not completely understand. And also sometimes it's one of potentially the worst day of their life or their loved one's life. They're processing a lot. It's a lot of information. So when I do my first evaluation, I do a history. And then a big part of it is saying, do you understand what's going on with your care? Has it been explained to you in a way that you can adequately say it back to me? Because I feel like that's really important that people truly know what's going on so that they can better anticipate what it's going to look like. And so that's a big part for me as the whole person is, do you understand what's going on? And let's talk already about discharge planning on day one, on admission, so that when that discharge comes, they feel prepared. They feel like they have all the information, and then they're better set up for success when they discharge. So kind of looking at it as a full perspective, that's a big part of mine, everyday conversations.
Yeah. And yours may be a little bit different because you're dealing with different kinds of patients, but do you want to share, Pam?
Yeah, I would love to. I think that's such a great answer. And Annie's answer juxtaposed with mine is so telling about how social work can truly look so wildly different, like even within the same hospital, unit to unit or role to role. So for me, my answer is that we really look at person and environment. So even though the patient in the acute setting is, of course, in the hospital, we are looking past that hospital setting for the patient and the family. So like what vulnerabilities does the patient have in transitioning home? Like how can we help support this mother and or this family and having the resources that they need to be successful? And that really can look like so many things. It can look like mental health. It can look like financial. It can look like what are your parenting supports? I'm pulling this off the top of my head, but like, do you have mice? Like it can vary so much. And so that whole person care outside of the medical side is I'm speaking for both of us when I say we feel like it's crucial. We are looking at what factors in a patient's life impact their medical care and their medical needs, because truly it all really ties together. If you don't have a ride to your doctor's appointment, you're not going to be able to get to your doctor's appointment. If you can't afford your medication, that's a hindrance. And so there are so many things that we're looking at, and every day it's different. Yeah.
Well, that really tees up my next question. Like, okay, so you find out about this. How do you really help patients who are medically ready to leave the hospital, but they don't have that safe support at the home? And I know it might be different for each of you. How do you help patients with that?
So it's a matter of asking questions and listening really carefully to what the answers are. So we feel social work, the basis of social work is the strengths-based perspective. So if we can help a patient or a person or a family member really to recognize what are the strengths in your situation, or what assets, though maybe it doesn't feel like that right off the bat, how can we make what you have or what you need work for you? I don't know if that's really answering your question. But sometimes it's just a matter of getting really creative and also encouraging the patient to think through from a different point of view.
Yeah. And kind of to go off of Pam too, I like to say there's never an exact perfect discharge plan. There isn't. And so sometimes, especially if a patient's medically ready, that also goes into our advocacy side as social workers. It's where I, in rounds will go up to a doctor and say, I understand the patient's medically ready, but I don't have a plan for them and they're not going to be successful. They're going to readmit. So that's part of our advocacy to say, how can we get creative? Let's lean on our support systems. A lot of people don't like asking for help. They want their autonomy. They want to be able to do things. So it's empowering them to say, hey, at this point, you might need some help and it's okay to ask for help. I can help call people.
Yeah.
If you don't want to call your neighbor or friend, I can do it with you, to empower them to say, let's get creative and come up with a plan. We also lean on our social work team. We have about 40 social workers in our hospitals. So we meet once a week where we go through what we call complex situations. So we all meet together, present complex cases to our care team with social workers from all different backgrounds so that everyone can give their perspective and maybe a different idea or suggestion that I myself hadn't thought of before.
Totally.
Yeah.
Piggybacking off of that, we are extraordinarily team focused. We live in the gray. That's a huge part of what our job looks like day to day. Is there's a lot of gray, and so we rely heavily on one another, and we have a really close dynamic, and it feels so good to have our teammates and be able to say what should I do in this situation, or what do you think, or do you have any ideas that I didn't have related to resources or planning or discharge or otherwise. And so I can't say strongly enough how much I absolutely love being on a team of other, really warm-hearted individuals.
Well, that's great. I mean, I was going to ask you about that because you are at a bigger hospital, so you have a bigger group, but it sounds like you even have the team beyond your social work team. You're working with physicians and others to advocate. It sounds like that is also a part of the team, which a rural hospital would have. Is that correct?
Absolutely. For my team on the ICU, we do rounds daily at 9:30 where the entire care team, doctors, nurses, therapists, pharmacists, everyone sits together and goes through every single patient on our unit every single day. And all of our units do that on the adult side. So everyone is very involved and very interconnected in the care planning process.
Yeah, absolutely. And adding to that, my perspective is that social work is really viewed as an integral part of that team. So everybody obviously has a distinct role to play, but it's my experience that social work is really highly valued in that conversation because we do so much social side of people's lives, and we cover so much of the social and the emotional and the environmental piece. It's been my experience that the other disciplines that are present on the team really truly look to social work to say, what is your take on this? What's your opinion? What's the next best step? So it's just a really, at our hospital anyway, it's a really well-functioning team, interdisciplinary. And
That's great. Learning a lot here about social work, and I could keep asking, but I know there's a lot of folks online that have questions in the chat, so I always have to remember that. So, Jaren, chat, what's going on in the chat? What questions do we have from students all over the state?
Yeah, have a number of them. So thank you. And maybe first to you both, I think a lot of attendees are familiar with social workers and some of these types of roles that and responsibilities that you've hit on already, including discharge planning. But I think it's from some of the questions in the chat, could you maybe just define a little bit more of what is discharge planning? What does that really look like? And then we'll get to a lot more, but let's start with that. Either of you, if you want to take a stab at it.
Yeah, so I can kind of talk about kind of my day-to-day interactions with patients. So all of us social workers see every inpatient patient that's an inpatient in the hospital within 24 hours of admission. And then we have an initial evaluation. So I go in, meet with the patient, I confirm where are they living? Who are they living with? What support systems do they have? Do they need assistance in the home? Are they able to transport? Any financial concerns? Any food insecurity concerns? Do they have, a decision maker, medical decision maker, if they're unable to? So I kind of get that history. And then I kind of, again, coordinate with the care team. I kind of explain, I help with care coordination and discharge planning. Right now, I am going to follow along until I get further recommendations from the care team till we get closer to discharge. And then as we go along, say the care team therapy recommends a rehab facility for a patient and the doctors and everyone's on board, then I follow back up and I say, hey, this is what's recommended. As social workers, arrange all of that. So if a patient needs home health or rehab or hospice, we would do that. I like to say sometimes our work is behind the scenes. Mm-hmm. I'll send all the referrals. I'll coordinate with all the agencies and facilities on the behalf of the patient. I will follow back up with the patient and family, give them the list, give them the choice, answer any questions. I'll also verify their insurance, if insurance can pay. If they go to rehab, I'll set up transportation for them. So that's kind of a general plan. And then obviously any other complex family dynamics too, especially on ICU. Sometimes we have families come from all over, especially if someone's very critically ill. So that's part of more of the care coordination side. I determine, hey, who is our spokesperson? Unfortunately, our care team can't talk to 6 people a day. It's just, we don't have the time and the capabilities to do that. So who is our person we're talking to? How are you going to communicate with the rest of the family? And kind of so on and so forth. So that's kind of my day to day.
Anything you would add, Pam, or does that align overall?
Yeah, I thought that was a great answer. For discharge planning, we are ensuring that when the patient leaves us, they're as set up as possible for success as much as we can do. So for everybody that looks different, but at time of discharge, what does this patient need to have or have in place in order to feel confident, safe? Safe's a big word that we use all the time. And safe can mean a lot of things. And really successful so that they don't have to come back and see us. We want them to go home and reintegrate back into their home environment smoothly and have that transition be easy for them.
Yeah. Well, again, like you said, Annie, behind the scenes maybe, but absolutely very important work that you guys are doing. So that's, I think, a really excellent, helpful explanation. So next question we have in the chat from Olivia. Olivia's wanting to know, so how many patients are you seeing and having to work with on a day-to-day basis?
Yeah, sure. So I can start with that. It varies. I would say, like for today, for example, I have 7 patients to see, and each patient can have a totally different length of time that I spend. Sometimes it's really quick and easy and their needs are minimal. Other times it takes a long time and it takes, a lot of effort, but it varies from day to day. Every day truly looks very different from the previous or the next. But that I would say anywhere from say 7 to 10 is safe number to say.
And then on my side, all of our units are a little bit different. So ICU here at our hospital has 26 beds. I have the entire unit. So if we have 26 beds, we have 26 patients. We don't typically get that high. Usually the goal from our management to make sure we're doing things safely and we're capable of our job is around 16 patients. Again, my 16 patients might be different than someone on a med surge unit. It just varies, but that's kind of my our typical goal is 16. Like Pam said, I can have 6 and be working all day long with those patients, especially on ICU. It might be a more complex explanation of things, but that's kind of the goal.
Okay. And hopefully get to maybe 1 or 2 more questions. I know we're getting close to the end of the time here, but this is definitely a lot of interest from our attendees. How do you deal with some of the sadness and pain that you know your patients and the families are feeling? Do you take it home with you? Do you have a mechanism to cope with that? Annie, do you want to take that one first?
Yeah. So again, working on ICU, we see a lot of difficult cases. Unfortunately, we do see a lot of deaths. It's just part of the job. Boundaries are really important. One thing that I kind of keep in my mind is a successful discharge can also mean navigating with families to a successful death in a way. It's a different perspective. It's a different way to think about it, but that's kind of part of, there's 2 ways, and so allowing families that opportunity to navigate the discharge, even in death, is really changing that perspective and realizing we're still helping someone, even if it is difficult, and acknowledging it's going to be hard.
Yeah. And my answer would be that I really think that boundary that Annie mentioned is a skill, much like any other skill that we have in the workplace setting. Yeah. So it is a skill that I, when I first started, was terrible at this. And the thing is that if you're not able to process the sad and the hard in a way that works, it's hard to stay in the field. And that is just kind of the way it is. And so if you can utilize whatever feels good in your life that we would call self-care and to have a boundary, you're able then to help more people. That's kind of how I look at it. So it doesn't make me not kind. It doesn't make me not loving, that I don't get brokenhearted at every turn. It makes me able to best serve my next family. And so that's truly a skill that, you have to practice. And what that means is when you go home, you do the things that feel really good, like if it's walking in the grass, if it's sipping water, having a tea, what's calling your best friend, like those things keep you going. And so you can then gain the reward from the career, because for sure the reward definitely is so, so, so big in social work in a hospital.
Well, those are great takeaways to leave off on, and certainly things for attendees to think about if social work is something that they are interested in. So Cindy, that's the end of our time. So I'll turn things back over to you for the next segment.
Thank you so much for joining us, Annie and Pam, and for sharing your insight on careers in social services.